welcome to another of the webinars supported by BOD Pharmaceuticals from Australia. And this one is on very topical, of course, on long COVID, managing symptoms with cannabinoid therapy. And that couldn't be more topical, could it, as we're all looking possibly to get booster jabs, and the Omicron is now creeping across Europe, which sounds, I think they named it deliberately to be for a scary name, didn't they? But anyway, sadly, we have a big issue really now worldwide about long COVID. So anything that can help it is going to be useful. And there may be some early indications that cannabinoid therapy, particularly high CBD, but we'll hear about that later, may indeed help at least some of the symptoms of long COVID. Whether it reduces the chances of long COVID is yet to be seen. So that's the topic of tonight. And you don't want to hear me chattering on, so I'm just going to say that's me. This is obviously through the Medical Cannabis Clinicians Society, of which I am chair, and many thanks to Kate, who's behind the scenes here, who's, as ever, organized everything. So thank you for that. And our speakers tonight from Australia, first is going to be Dr. Anjali Didi, who's a general practitioner, but is a cannabis prescriber, and is going to talk to us about her experience of both cannabis and particularly long COVID in a couple of cases. So welcome and thank you. And then we're going to hear also from Adele Hosseini, who has talked to us before. So welcome back. Adele is Chief Scientific Officer of BOD, is going to tell us a little bit about the product Medicapolis at the end, and then we're going to open this up for questions. And we have Despina Lord also from BOD on the call, also keeping us in order, I think. Good. And then questions at the end. So when you ask questions, can you put them in the Q&A, please? Not the chat. The Q&A will be good, and we'll answer those at the end. Just before we pass over, a brief advert for the Medical Cannabis Clinicians Society. I hope most of you are members. It's open to any clinician. It is mainly UK, clearly, but it's open to actually, we have worldwide members now from the States, Canada, Uruguay, Nigeria, and Australia. So it's becoming a worldwide Medical Cannabis Clinicians Society, but it obviously started in the UK, and I would encourage anyone on the call tonight who is not a member to join it, because although I would say this, wouldn't I think it's very good and very helpful as a support for those who want to prescribe cannabis. We have a peer support networking system. We produce some very good leaflets and booklets, as you see just a couple on the screen there, how to begin prescribing, for example. We have these events like tonight. I think we've done 30 or 40 of these webinars now. And when the world opens up a little bit more than it is, we'll go back to face-to-face events. We just had one before COVID came along. And we'll go around we were going around universities. We'll start that again as well. So we produce a lot of guides and training. We have licensed product information, what's available in the UK, and expert prescribing guidelines. And we have, I think it really does work really well, actually, as a Google group, 2 Google groups, one for all members and one for doctor prescribing members only. And if you write a question in the Google group, you will get an answer worldwide, actually, from some of our experienced colleagues abroad outside the UK who can help and guide about any particular clinical problems. That really does work, actually. And we have a searchable evidence hub as well. So for typing in things, I don't know if we've got anything on long COVID at the moment, but for example, type in anxiety and it'll come up with some papers if you want to research a particular topic. And we try and keep that up to date. And we're also relevant for the UK. It was difficult at first for prescribing doctors to get insurance. That is now not an issue. We can access insurance for doctors and for clinics and dispensaries. So for businesses as well as the individual doctors prescribing through Towergate, and you can access that through the society if you join it, which is very worthwhile joining because it's only £90 a year. There you go. That's my advert for the Medical Cannabis Clinicians Society. Down and there's the website where you can join it. So I will stop sharing my screen now and pass over to Adele, who's going to share her screen, but mainly for the speaking point of view. Angela, you're going to do it yourself, aren't you? So here we are. I'll pass over to Anjali Didi to talk to us about long COVID, therapeutic potential of cannabinoid therapy. Thank you very much. All yours. You're on mute, Anjali.
Perfect. Thank you very much for having me. So I'm actually a UK trained doctor, came over here about 4 or 5 years ago. So things have developed in the UK in terms of prescribing cannabis, but here I feel like we've accelerated quite quickly. So I've been prescribing since I got here in 2016. I work as a GP and I teach at the University of Sydney. This is the overview that we're going to do today. So thank you, Professor Barnes, for the introduction and some help earlier about where you are all at in the UK prescribing. Hopefully I'm going to pitch this correctly, but if I've not managed to cover what you need, please do pop that into the questions and answers. Hopefully we can get to that at the end. So I'm going to go through a little bit about cannabinoids. Just before that, the disclosures for me is that I have received an honorarium for today, and some lunches from Pod Australia in meetings and from another couple of companies involved in medicinal cannabis in Australia. You are probably familiar with the fact that we have an endocannabinoid system within ourselves. We started to realize that when we found the compound AEA in the 1970s. That's a naturally occurring endocannabinoid, and it acts at the CB1 receptor, which has also been found after the AEA. That's predominantly found in the brain. We also have found a CB2 receptor that's in the spleen, the gut, the eyes, and the skin. So that's very important to know, because we're actually talking about medicinal cannabis that is affecting a system that's already within us. And how to help ourselves with this system is something that we still need some research on, in terms of if we agonize the CB1 receptor, which one of the compounds does in medicinal cannabis, or partially agonize the CB2 receptor, which one's better for us is something that's still under research. There are also lots of other receptors in the endocannabinoid system that are under research right now. The G protein coupled receptor, the ion channels and nuclear receptors, definitely something out of my domain, but interesting to read when the research comes out. Do you mind just going to the next slide, because it looks my remote control is not working, Adele? Thank you. Thank you very much. So we had talked about endogenous cannabinoids, and that's to the left of your screen. And we talked about the two compounds that we know a lot about. And then we're focusing on the exogenous, which is to the right of your screen. Part of them are the plant-based cannabinoids, which are called phytocannabinoids. There's also synthetics that are available, nibolone, things that are used in MS. But today we're talking about the phytocannabinoids, and there's many compounds in the plant marijuana. And there are different strains, which you may have heard of. All the two main strains that are talked about are the indica and sativa, which is a different topic entirely. But the main two that have been researched are the CBD and THC, which I'm going to go into a little bit more. There are also other compounds that have been recently discovered, and there are some animal studies that are important about those. Some of those are CBG, CBC, CBDV, and I'm just going to go to the next slide to talk more about those. So this is actually a very intensive slide, so I want you to just focus on maybe the one column. So the first column is CBD, which we've all heard about. It's a non-psychoactive, non-intoxicating compound that has many studies, 20 that will be referenced for you, and you can request the slides and the references for yourself that help with anxiety. There are studies for anti-inflammation that prove that it would be slightly anti-inflammatory. CBD does work at the 5-HT receptor, which helps with serotonin, and therefore we have thought that it helps with anxiety and possibly sleep. THC could be intoxicating if the dose is slightly higher. CBD is counteracting to the THC intoxication. That's also been studied quite a lot in anti-inflammatory purposes. But the biggest thing it's been used for in quantities in combination with CBD in palliative care is as an antiemetic, an appetite stimulator, an analgesic, and possibly a muscle relaxant. In MS, it's also helpful. And we know that Sativex, which is the synthetic compound in the UK that's been licensed since 2003, has been used with a CB1 agonist, which is a THC type property which helps with MS and muscle properties. CBG, CBC, and CBDV, which are less known, I think, or maybe because you're part of the Cannabis Society, you know them. They are non-intoxicating and have been studied recently, and they're very interesting. So CBG has been in mice trials, and it's been shown to help with, I think it was skin tumor response. So in vivo, in animal studies, it's supposed to produce some apoptosis. And there is a study for you to have a read about that. So that's very interesting. CBC, again, non-intoxicating, and it's a derivative of CBG, which is the parent compound. And that's been used in studies for inflammatory bowel disease, also in mice animal models for pediatric epilepsy and Dravet syndrome. So University of Sydney has shown that in mice with febrile seizures, it reduces the convulsion potential by 40%. That's actually CBDV and CBC. So very interesting information coming out. Oops. Actually, I think I've already covered most of these slides by talking through them in the previous one, but when you request slides, this would go into it in a little bit more detail. So THC acts at the CB1 receptor as an agonist. It is responsible for intoxicating effects in high doses, and that's important to know when you prescribe, because the idea is that CBD is known to counteract that intoxicating effect. So even though that's probably something that people worry about when they first start to prescribe in low doses or even in 50-50 doses, it's unlikely. And the rule is always start low, go slow. And I'll go through a little bit about dosing and how kind of what we're looking for a bit later in the presentation. It is very good in terms of its act on nausea and vomiting, and therefore very widely prescribed in Australia for palliative care. CBD, as we said, is non-intoxicating and sometimes counteracts the intoxicating effect of THC. When we smoke recreational marijuana, we have a very high concentration of THC, but of course, medicinally, we can balance out the product or make it a CBD dominant product, which then helps us understand that we're being safe in our prescribing. It acts as a low affinity for the CB2 receptor and also helps with the 5-HT1A receptor, which is probably where it has its anxiolytic effects. And I had said that it's actually, there's some advancing research in its anticonvulsant effect, but actually the other minor compounds of medicinal marijuana have been widely trialed here at the University of Sydney for the same. Another great slide telling you a little bit more and giving you the reference for the anticonvulsant study at the bottom. Again, CBDV, CBG, very minor amounts in medicinal cannabis. Sorry, even in the plant marijuana, it's very, very small amount of cannabinoid in there. Very relevant to our prescribing is what's the interaction with other medication. And I hope I'm pitching it right and you, this is helpful. This is actually a table I use kind of every day, and the reference is there for you if you want to tab it in your internet browser. But it tells us that, you know, the medicinal cannabis does interact with CYP enzymes and what it might do to some of the substrates of the enzyme. And I always remember that the CYP enzymes are usually made to go slower. And therefore their substrates would be slightly higher in concentration. Now, in terms of pharmacokinetics, we probably couldn't put a percentage on it, but it's important to know that if we have a substrate that might cause some intoxicating effects or toxicity, then we might want to consider reducing the dose if we are able to. So if there's concomitant antidepressant prescription, sometimes I consider reducing it or following up the patient a little bit quicker, because some of those are slightly higher. So that's a CYP2C19 substrate. I don't know where the UK is at, but even GPs here can actually request pharmacogenomics per patient. I don't know if that's where you're at now. So we can actually tell whether you have a fast metabolizer of the CYP219 or the 3A4, which is very useful for us if we're, using this for epilepsy, and anti-epileptic drugs go through that, or antidepressants. If we don't have that in 2016, when I did start to prescribe, if we don't have that information, which I didn't then, the idea would be is to reduce possibly that concomitant medication or go very slow on the initial prescription. Our second phase metabolism of medicinal marijuana is carried out by transferases, and in the same journal, it tells you that what might be affected with the reduction in the metabolism through transferases, or the clearance of the second phase enzymes, which are the transferases, and one of those would be hydromorphone. So if we're doing this in somebody who's using this as a therapy, and they're using they're with a substance misuse clinic, for example, with methadone, and that's something to be aware of. Some opioids go through that same phase in the transferases, and therefore they may also be slightly increased in their effect, and just reducing the dose a little bit is very useful. In practice, I have to say, in the years that I have used this, I haven't seen that effect in terms of the opioids. I have definitely gone very slow just in my practice with the SSRIs because of the initial agitation effect that they may cause, and therefore I feel like I haven't changed my practice very much. So I always start at a lower dose than the licensed dose, and I might be starting at things like 1 every other day or half every other day for someone with a low BMI. But if you've had good results with people on the same licensed dose, then you may consider reducing it a tiny bit. So on we come to long COVID, and that's something that I was labeling a set of symptoms that I had seen with people that I actually inherited from the UK. I have to say now the WHO have recognized that in November, and they have defined it as a set of symptoms appearing typically 2 months post the acute infection of COVID. And they are now calling it the post-COVID-19 syndrome, or post-acute sequelae of COVID, PASC, or chronic COVID syndrome. So that was just on the 25th of November, they've decided to classify that. So even though we publicized this lecture prior, calling it long COVID, I feel like we've all got accustomed to calling it that here, and I don't know if that's what's been adopted in the UK. We now have to change the way we speak and call it PASC, post-acute sequelae of COVID-19. So some of the symptoms that have been described in case reports and in my practice have included insomnia, depression and anxiety, fatigability, that's physical and mental, shortness of breath, and cough, generally shortness of breath more than cough after the acute infection had subsided. Pain in different places, joints, headaches, chest pain, and myalgia. Neurocognitive dysfunction, fasciculations, involuntary movement, and anosmia that persists. I haven't seen it, but case reports have shown repeated pyrexia and fever, and dizziness on standing, or if we want to combine that with a diagnosis of POTS, which has been described, so postural tachycardia syndrome, we could pop that instead of the dizziness on standing on that list. There's a lot of research in CBD in sleep, and that's really where I initially considered prescribing medicinal cannabis and the cannabinoids in post-PACS, post-acute COVID syndrome. And you'll see in the case study where I decided to position the prescription. I was in fact quite lucky with one of the patients I'm presenting because they had already had quite a lot of investigation in London. So I've listed quite a few, with the help of Adele, thank you very much, listed quite a few studies where we have had research into how our sleep patterns change with CBD. There are some studies that have shown that it hasn't impacted our sleep study graphs when we do our sleep studies, and some of them have shown some qualitative improvement from patient questionnaires. Some people say that it increases duration of sleep in their studies. I think stage 3 and 4 rather than REM. I don't think it's got a lot of research on REM improvement in terms of length in REM. There is, I think, a few studies that have been done in America for THC in its role in rapid eye movement sleep and how it helps people maintain themselves in rapid eye movement and not wake up. And therefore, I think they've transposed that and THC products are being considered, CBD dominant THC products are being considered in sleep apnea and people with REM or sleep issues. But that's just a little overview of why I considered the prescription. So if we move on to the case study, I think I'm running on time. Adele, you're going to give me a little heads up if I'm going too slow. So I have a 42-year-old patient who came to see me initially earlier this year. His initial infection was in another country in March with an acute illness of loss of smell, and he couldn't smell his coffee. He was quite well for about 3 or 4 days just with the loss of smell, and because he had heard that this could possibly be a COVID infection, he was aware what he had to look out for. He then had quite a lot of diarrhea. It was diarrhea dominant, his acute infection with myalgia. That then changed from day 10 to headaches, night sweats, and breathlessness with cough. The biggest thing about him was that everything got worse when he was lying down. So lots of orthopnea, and he was sleeping on 2 or 3 pillows. And he, at that time in March, I understand in the UK, there was no COVID testing in terms of swabbing, or if there was, it was very difficult to access. So he kind of by himself, and his GP thought that he had a COVID infection, but he wasn't able to diagnose himself exactly with COVID. So he actually went back to work, I think it was week 5, but he felt absolutely awful and was sent home. And that was after a day of being at work because he was coughing and he's not supposed to be there. He is works in the finance industry and worked quite hard. And he's never been well since the infection, which I'll go into. And he had quite a lot of disturbance with muscle fasciculations all over his body, which in turn, he said, caused a lot of anxiety. And he felt at the time may have caused an insomnia pattern. The fasciculation stopped him being able to sleep, or was it something else? But that's the story he told me at the time. He was thoroughly investigated because he was very lucky to have private insurance in the UK. So I felt this was a really good case to go through because we can rule out quite a lot of things and know what the investigations are showing quite quickly. Whereas with some other patients, some of their symptoms might go under the radar because they may be thought of as a possible chest infection or the COVID chest or other things without those investigations saying that actually that's not bad. So as I had said, that his premorbid function was really very good. He had a very stressful corporate job, woke up in the morning to do lots of exercise in group fitness activity at the gym, very high intensity, sometimes slotted one in at lunchtime. And then after work, went and socialized, which was part of his job. He had no chronic health conditions, but he did mention he did have asthma and possibly only a blue inhaler when he was younger. And he was known to have some allergies seasonally when he was younger and was on antihistamines on and off over the counter, but not as an adult, as a child. So he ended up coming to see me, continuing to have, and this is now 9 months after his acute infection, he had breathlessness on exertion, orthopnea, so still sleeping on 1 or 2 pillows, heart palpitations, not always on exertion. And usually he felt they happened at night. So I wondered if this was linked to anxiety, but he has not been working since April 2020. And I'm going to go through a timeline in the next few slides, but I'm just going to go through the overall picture of what I saw in January. He also had some rolling, thumb pill rolling, which really worried him, and he had learned to hold, and it was only his right hand. So he had learned to hold his right hand as he sat and cross his legs to prevent the fasciculations taking over from his thought process, because they really were quite florid for him, and they interacted with the way he thought because they were uncomfortable. He did feel that he couldn't think as well as he used to be able to, but I had no way to measure that, and neither did he. He was fatigued enough not to be able to walk his daughter to school here in January 2021. And that was around a 10-15 minute walk. But in Sydney, there are hills. So I feel that maybe it was the hills, but he told me that even back in London, he wasn't able to walk her to school. Lots of pain in his muscles, usually after fasciculation spurts, like when they got worse. Still had chest pain, and he said that that came on centrally, not on exertion again, not always related to palpitations, and that could happen as a stabbing type pain, but the stab would stay for a few minutes, and it was a bit debilitating for him. Yeah. And the biggest thing I wanted to talk about was that he couldn't sleep, and he had learned that he had tried quite a few things before meeting me, including some temazepam, some zopiclone, and he had tried some amitriptyline, which he continued to be on. Nothing really helped very much, and he would concomitantly use alcohol to try and put him to bed. And unfortunately, it blurs things a bit, but he told me from June 2020, when the PACS, the post-acute COVID-19 sequelae, had come in, he hadn't been able to sleep, sometimes all night. And he felt that maybe looking back, it was the fasciculations, but also a speed of thought in his head, whether that was lockdown, his worry about the symptoms, it could have been an amalgamation of things. But I feel like we've just got to take all those symptoms and treat those rather than work out where the pathology lies. So he was given sleeping tablets, but that made his fatigability worse. So he had seen a number of physicians privately, and he had been started on a inhaler. He had been trialed on Symbicort, which hadn't worked at all. And he felt that he didn't have the drive to be able to breathe in the way that it required. He then had been changed to Ravar, which I don't have here in Australia, and then finally got on to Clenil. He'd been put on bisoprolol in a low dose for his palpitations, but he went on and off that. And he's as somebody who goes on and off his medications and requires a follow-up to carry on. He'd been advised to use prednisolone at a dose of 30 milligrams for a week every time he had a breathless attack, and those attacks started when he really couldn't lie flat at all and needed 4 pillows, but also coughing in the day got worse, with breathless in the day getting worse. And I'll go through that in the timeline. He was on amitriptyline, 10 milligrams once at night, fexofenadine, nizatidine, and anecdotally, the last professor who had seen him had started him on vitamin C and a bit of zinc. And he had got a prescription of benzodiazepines, but he had stopped it due to kind of the hangover effect in the morning and the fact that fatigability was just a whole lot worse, even taking half as zopiclone at nighttime. I have to say, by the time he saw me, he was trying his best not to drink alcohol, and we had talked about that. And the weather is such here that we had talked about going for a walk in the morning in the sun. because it was summer in January 2021, sorry. And by the time he had seen me, he had worked out that the days that he doesn't sleep, all of the symptoms are worse, including how frequent the fasciculations were. And for him, the fasciculations were on his buttocks and his thighs. We decided, due to that and his history, we would increase the amitriptyline and try and help him a little. I wonder if you have suvorexant, which turns off the awake center. It's a dual orexin receptor antagonist. So I tried that. And it shouldn't have caused him a hangover effect because of the fact that it doesn't help with the hypothalamus and the sleep center. He was already on melatonin at a 2 milligram dose, circadian, which you have, but there's evidence we can go up to 10 milligrams. So we went up to 5. And I added in a bit of 400 milligrams of magnesium at night to see if it helped relax some of his muscles. Reviewed him in about a month. Unfortunately, his fatigue still remained, but he could definitely do a walk now. And he was trying to walk with his wife and his daughter to drop her to school, but limited again by breathlessness and fatigue, and needed an afternoon nap and lots of palpitations that, because he's not working, he could manage because he used to breathe through it, stay at home. He's been signed off now on long-term leave, and at this point he's now resigned from the UK job and took voluntary redundancy as he came into Australia to be with his extended family he had not seen for many years, actually decades. March, he came in with severe reflux, lots of burning, no dysphagia, but really nothing was helping. And he was put on nystatin for possible reflux in England. And I added in a PPI, not sure if that's supposed to be the case. And then we can get gastroscopies quite quickly here, which is nice. And we got that in a couple of weeks, and there was a very small segment of Barrett's. Palpitations were worsening. I wondered if that was to do with the reflux. There was no postural drop or heart rate variability. So, you know, I was just checking for POTS and the development of that because there were some case reports about that. I also didn't want to exacerbate any issues. I restarted bisoprolol because he had taken himself off it. And he told me in the future that's because since his COVID-19 acute infection, he had issues with libido that might be related to the fatigability, but he also had issues with the hardening of the erection, which is also very important for quality of life. And he had tried to stop himself from all medications. He's a young 42-year-old, was never on anything. And you'll see that he tries to stop himself off at everything because he doesn't want to be on anything. So he had stopped his, sorry, I've called it NDET, which is a trade name. I shouldn't do that because I should be generic like we are taught in the UK. Here it's very trade name orientated like we were in the UK 10 years ago. So he stopped his amitriptyline, but he continued only his melatonin at that time. So I reviewed him again a month later. And at this point, I started the suvorexant, restarted bisoprolol. He's had a high dose PPI. And in April, he had what he felt was a COVID crash. And he tells me that he's had a COVID crash, which is what the patients are calling it, back in September in 2020, where he was able to walk a little bit and was very fatigued. But in September, he had a 2-week period of not being able to get out of bed, enough that his wife was bringing him bedpans or his makeshift bedpans to actually go to the toilet in the bed, and he wasn't able to leave the bed and he needed some help. His wife couldn't, she's quite small build, and I think that was the crash period when they decided they would leave the country because they needed help at home. So again in April, he had an overwhelming feeling that that was happening again. And it usually happens when he wakes up, he finds that his joints, aches and pains kind of are much worse in the legs. Fasciculations are worse, doesn't have any balance, not always dizziness, but just couldn't balance because he can't control his legs. He had stopped amitriptyline, as you remember. I have restarted it now at this point. I've asked him not to restart, to stop anything without asking me. And we discussed a trial of medicinal cannabis at the time. And here we have to apply for an authority to prescribe because it is prescribed only, and no medicinal cannabis really here is a food supplement, which I know in the UK it is, which I feel like you're very lucky with in a way. But I'll tell you why it's very important to prescribe medicinal cannabis and not use food supplements. And here there are some international companies that we can order in, but I tried to allow my patients to understand why we shouldn't do that. Going back to the case, he's very tearful at this point because it's been nearly over a year that he's had symptoms, very tearful at this point, and he's not a man who usually shows his emotions, and he's very smiley in his corporate forefront personality. We discussed some SSRIs and I started him on fluoxetine. He had already been trialed on some Lexapro the year before with a GP in the UK. The Lexapro is this escitalopram, I'm sorry. I reviewed him after 5 days, and he actually called 2 or 3 days after he started, saying that he's had some shivering episodes and lots of agitation, lots of anxiety, really can't sleep with it, quite a severe initiation effect. So I added in some Seroquel, which sometimes helps with that initiation effect. And I hope that then fluoxetine he would manage to get used to after a week, because his anxiety was getting quite bad. He engaged with a psychologist, and again here at the time everyone had increased their hours and we can see psychologists privately, so he started to see a psychologist just the twice that week that I had started the fluoxetine, but he wasn't able to concentrate or talk. By the end of April, oops, I've actually missed that bit. I had received the authority certificate to prescribe. It usually takes 24 hours here. He was still on Seroquel, but again, it was causing a hangover effect. But at this point, he didn't really need to look after his daughter, and he was sleeping till 10, and I think that was acceptable. He had help at home. And we decided that we might try a little bit of medicinal cannabis at the time, because he had been on everything else to support his sleep. And we know that when he doesn't sleep, all of his symptoms are much worse. I reduced the dose of Seroquel, so we were on 50 milligrams fast release to help with anxiety. And I asked him to quarter that, which was very hard. And I'm sure it's crumbs that we get. I just didn't want him to be too sleepy in the evenings. So we did a quarter dose of Seroquel, and we started a very tiny dose of BOD Medicabilis. It's not actually a tiny dose because the amount of CBD is 100 milligram per mil, and we started at 0.2 mils once at night, and that's 20 milligrams of CBD and a less than 2% content of THC in the one that you have in the UK. In early May, of course, we've reduced the Seroquel now. The hangover feeling the next day is much less. He's sleeping, and it may be a little bit of the SSRI, it may be a little bit of the Seroquel, but it may be also a little bit of the CBD. I cannot differentiate that, but I will say to you that he generally felt in early May that he was less anxious in the day. He was now on fluoxetine every other day, but asking me if he could discontinue it because it had affected him again with libido, and the fact that he couldn't reach orgasm, which is also something important with the SSRIs. And I was glad that he was very honest with me about that. So we decided, let's try. And I asked him to see me every week, which I had the able to do in this in Australia. I'm not sure if GPs can do that in the UK. Late May, he had sharp stabbing pain. He had discontinued his medication again, and I asked him to restart everything. At this point, we had decided to increase the Medicabilis to 20 milligrams twice a day, so 0.2 mil, 0.2 mil in the evening. But he came back in June and said that actually made him quite sleepy. And lots of people aren't very affected by the CBD dominant products this quickly. So he was quite reactive to that. He had stopped his amitriptyline, but he continued in Seroquel every other day, his melatonin and nisadotine to help his reflux. On the advice of his gastroenterologist, it was a a short segment at Barrett's, and he stopped his omeprazole. He went to see a private psychiatrist who asked him to start duloxetine, which might help with a libido effect. But he decided that he didn't want to try the SSRIs because he generally felt okay in managing and able to do what he could do in the day. I was a bit worried about this April episode of his anxiety, so I did want to chase a little bit and try and support him in his decisions to go back to work soon. So I asked him to try some vortioxetine, which is a new age SSRI, but continue with the CBD. And that's something he never actually stopped, because he felt that the 1 or 2 days he stopped it, the day after he didn't feel very well in terms of fatigability, but it's all very qualitative. And he was being followed up in a pilot, in an observational trial here. So I know Adele has some graphs that she could share with you on request that kind of tells you his story and how his qualitative answers match his dosing. He was able to do 10-minute walks, and now he's walking his daughter to school. Okay, so that was kind of him in a nutshell. I don't know whether you've got questions about him or you'd like to wait, and maybe I'll wait for Adele to let me know which one we would do. But I have another case, a very small case, because this was very well investigated. I think the one thing about this chap was he came to me from England, and he had, if you see on the first slides, he had a CTPA, he had a cardiac echo, ECG, Holter monitor, an MRI of the heart, all showing that everything was negative. He had respiratory function tests once every 3 months from 3 different respiratory consultants, and he had gone to the emergency 5 times between August and December 2020 before he came to Australia with acute breathless episodes. So he was very debilitated with this PAX syndrome. Okay. Adele, do you have any questions?
I think if we pass on, if we just do the second case fairly quickly, because we've only really got about another 15 minutes, and Adele's got a few slides. If we just do if that's all right, Anjali, if you do this case fairly quickly, and then we'll pass over to Adele.
So this is a 36-year-old lady I met in September 2020. She was one of the first people that had COVID here because our case rate was very low. And she was a lawyer by profession. She had a lot of insomnia and anxiety. Again, was that to do with our lockdown? Was that to do with the COVID infection that she had in April 2020? She wasn't able to sleep, and to do with muscle aches and pains, she wasn't able to sleep. So she had tried lots of other medications, having seen another GP in another area, but she hadn't been working since May 2020 because she couldn't concentrate, and she felt that was to do with anxiety, and her function at work wasn't right. So she took sick leave, which she had built a lot of from her firm. She had tried again temazepam for helping sleep from a previous GP, amitriptyline, an SSRI, which had caused some agitation, and that had been changed to fluoxetine, which then she continued, and she was on already 1 every other day. I gave her a high dose vitamin D injection because her vitamin D came back at kind of 40-ish. And I wondered whether that was the aches and pains she was feeling. That helped a little. Yeah. I added some medicinal cannabis, again, a balanced product with 50% THC and 50% CBD. And that's because she didn't need to drive. And that definitely helped her daytime anxiety after a couple of months. I don't have such big slides on her because her symptoms were really based on the insomnia and the speed of thought. She didn't have a past history of anxiety, and she was very high functioning. I did ask her to come back for review. So she's a bit boring in that situation. Because she didn't come back since January 2020. Was she well? I wasn't sure, but she did ask me for a repeat prescription of the medicinal cannabis, which I did in June 2020, and she may be using a very small dose, and then it kind of stays for a long time. She hasn't asked me for a dose of fluoxetine. However, in Australia, we can see many different GPs, so she may be still on that prescription. So she let reception know after I bothered her around 3 or 4 times that she went back to work in February, a month after I started some prescriptions, and she will call in as she needs. So basically to stop me calling her. So I've taken her off the follow-up, but very important that, you know, she did ask for a repeat prescription in June. So I thought maybe that was a useful thing to ask. I did want to just go through a couple of other slides, Adele. The biggest thing about medicinal cannabis is start low, go slow. And the idea is the tissue level is increased every day that we're on the same dose. So how long do we wait? And I usually wait about 7 days. I know some practitioners wait 14 days before increasing dosing, even if there's no effect. Usually I start on once daily dosing, and because of the pharmacokinetic profile of the GI tract and how it goes in, you may end up with twice daily dosing just to split the dose and see how that goes. Some of my patients have then gone back to once daily dosing. What do we do next? It's an idea to have a written consent form, possibly, especially if we have some THC on board to identify what we have discussed with the patient. So we do have to, if there's a little bit of THC, it's a good idea to talk about psychoactive symptoms. Some of them might be a little bit of paranoia. I've never really seen that. Some people have told me a little bit that that might be happening, but very, very low level and didn't really know when it's a CBD dominant product. The idea about THC is that most governments feel that it impacts driving and impaired thinking. In England, there was a 2014 drug driving update, and it says that we shouldn't have any more than 0.2 micrograms per 100 milliliters. I know most companies show that there's a lot less of that in the body if the amount of THC is less than 2% in the product. And I understand that CBD dominant products can be sold over the counter, but the idea is you provide dosing and titration recommendations. In England, they are able to drive with low level THC, and I think you should read about the drug science behind that, and there's a couple of links that you could read behind that, and write a written consent form about if they took high doses to reconsider driving. Every product has, oh, sorry, may I do 2 more slides?
Yeah, if we could go fairly quickly, because if we really have to stop at 8. So yeah,
okay.
just
yes,
zoom through these.
I'll zoom through these ones. So the idea is every medicinal cannabis product has its own stamp. So it has its own amount of different cannabinoids in there. And we had talked about a few different cannabinoids before, CBD, THC. This particular product has some CBC in it, and Adele's going to go through exactly what they have got in this product, because every strain of medicinal cannabis that we cultivate has a slightly different content, which is important for your prescribing, because we talked about the different minor cannabinoids and how they may help with different etiologies and conditions. Also, we can try we also try and work out exactly what's in the bottle. So the MHRA would be checking. The idea is, if we say that there's less than 2% THC, can we agree that a food product would also have less than 2% THC? Of course, there would be some variability of batches, but generally when we've got companies that are making it and would be batch tested with MHRA and here the TGA, we would be a little bit more confident that we would stick to those boundaries. I'm going to leave you with Adele, thank you, with her product from Bod Australia.
Thank you so much, Dr. Didi. That was a really informative and interesting information that you provided. Because there is not much time, I've just breezed through my slides, so it won't be too much of the talk, because there are a few good questions that I would like to go through them with Professor Barnes and Dr. Didi as well. So the products that these case studies, 2 case studies that Dr. Didi was mentioning and talked about and was effective was the Medicabalis 5%. It is a pharmaceutical grade product that is available in the UK by prescription. And it has 50 milligram per mil of CBD standardized. But in addition to that, it does have other minor cannabinoids as well. It does have less than 2 milligram per mil of the THC. That makes it relatively safe, especially for when you are prescribing it to manage symptoms related to neurological or psychological effects, because the higher concentration of the THC may have a negative effects on the psychological symptoms such as anxiety. And if you're thinking that you want to prescribe CBD dominant products for symptoms associated with long COVID, specifically anxiety, then that might be a product of choice for you as well. It does have small amount of the CBG, which is about 1.5 milligram per mil. And also it has CBC and CBDV and other minor cannabinoids that altogether, they're going to count about 13 milligram. In addition, it does have like a terpene profiles. The quality of the medicabolase is, I think, the important things that you need to consider, that it is a pharmaceutical grade and batch to batch variability is very minimal. That gives that confidence that when you're prescribing it for your patients, that you will get the same results every single time. There are a couple of slides that I would leave with you to read through when you receive the slides. I won't go through them, but that's only just showing results of the surveys that's been done, independent surveys that's been done on the current CBD products available in the UK on the pharmacy or in the health shops. That shows that what's the quality of the products and how unreliable they might be if the patients choose to take them from just the over the shelf. So I'll leave that with you to go through it. But what I want to share with you is just the safety profile of medicabolase on this study that we've done. Just is the interim results that's been analyzing of the results, but we recruited about 500 patients on the observational study. The study just completed and we are cleaning the data and analyzing. Hopefully the full result would be available early next year. But the preliminary results showed that it's a very relative safe CBD, that out of 140 cases, we had only 23 incidents that was reported. And each of these incidents that's been reported, they were all very mild and they all been resolved very quickly. And if you look at the numbers, it's not really too many, like it's about the highest one that we had, the adverse events incidence was 6, and it was diarrhea, nausea, fatigue, headaches, and somnolence. And these are, again, very known and common adverse event that has been reported with CBD as well. Just leave you with this couple of slides that there are a number of the research that we are participating in the UK as well as in Australia. The one that is relevant is a long COVID feasibility study that we are about to embark. It's either in the couple of weeks, or if not, then it would definitely be in early January, with partnership with Drug Science, and the investigators is Dr. Elizabeth Iverson. And there are some resources available upon request that we would send you, but thank you so much for your time and just joining our webinar. Thanks, Professor Barnes.
And if people wanted to say, is that right, Professor Barnes, we'd be doing questions?
Yeah, we're going to move to some questions now. So thank you both very much. We've still got some time. We routinely overrun on these webinars, which is not a bad thing, but I promise not to overrun more than 10 minutes. So I promise we'll finish at 8:10 if we have enough questions. So let's have a look. Do you want to unshare the screen? Adele, I think you've got that. There we go. You can see us all now. Let's have a look at some of the questions. I think, and just before we start, I think there's pretty good evidence that as we've covered a little bit, that the symptoms of long COVID can be helped by cannabis, because we know it helps anxiety, we know it helps sleep. A big question. Sorry. Thank you, Kate, for reminding me no one can see me. Right. Not a great disadvantage. Now you put me off so much, I've forgotten what I was talking about now. Yeah, the question that we can't answer yet, but there is a theoretical reason, is can we actually reduce the numbers of long COVID because as you know, some of the long COVID is due to a cytokine storm, which is an overreaction of the immune system. And cannabinoids, generally CBD being anti-inflammatory, they actually reduce the incidence of long COVID as opposed to the symptoms of long COVID, which is a separate discussion. And that's something that there were some early indications from studies in Israel and Canada, but we are people around the world now looking at that more definitively. So if you're on CBD or at least a full spectrum cannabis, perhaps with a little bit of THC, can you actually slow down or reduce the incidence of long COVID? It's a really important question for global health, actually, but we can't yet answer it, I think is fair to say. So that's me rambling on. Let's have a quick look at some of the questions. And the first one is, how important is consistent cannabis for medical use? Not particularly on COVID, but how do you ensure cannabis consistency? Well, I'll just have a quick two-penneth and then others can chip in that, well, you can't make it totally consistent because it's a plant. There is a more inconsistency to a limited degree in the plant product than there is in the pharmaceutical product, because it's not a pharmaceutical product. It doesn't matter hugely because the individual dosing, you start low and go slow, as Anjali said, then you will reach the sweet spot of that particular strain, that particular batch, by just doing that each time. So it is important to be consistent as possible, but it can't be ever as consistent as a pharmaceutical product. And I don't think that hugely matters. So Anjali, did you want to come in there?
I was going to say that we may be oversupplied in Australia with many companies, and I have to choose my companies who show me their safety profiles and what kind of studies, because I do prescribe quite a lot. And of course, I don't know if you know, but I am monitoring the trial in the UK, which is very exciting. So if you did have patients that wanted to go into the trial, definitely contact Adele. I think that's very exciting. I've already got patients in the UK that would be going there. So in terms of consistent cannabis use, because I'm a prescriber, I do want consistent use, and that's why I choose to prescribe and not suggest a food product. I feel like for insurance purposes, if I'm registered as a practitioner, I want something that is MHRA regulated, or here in Australia, TGA regulated as a prescription product. Of course, the minor cannabinoids, they try and keep the same profile because they keep the same strain that they cultivate for that particular product. And it's important about the strain, it's important about where the medicinal marijuana is grown. And some people that haven't done very well with one product, I switch them. So the idea is that's something that I consider. These are the considerations. That there is no right answer. I don't know if Despina and Adele have some other comments.
Well, as you mentioned, that the consistency comes very important, that it's confidence for the doctors and also for patients as well, that they are receiving the same medicines, because medicinal cannabis shouldn't be anything different to any other medications that the patient's taking. But as Professor Barnes mentioned, that it is a lot more difficult to make that consistency. But as long as it's monitored from the manufacturing point of view, and it follows the good manufacturing process and is ticked by the regulators, that shows the consistency. And the couple of slides that I didn't go through, but hopefully you would have time to go through it yourself on your own time, that shows that how important it is to choose your products wisely, because not every product's got that consistency. So we do independent, in addition to having all these compliant and certificates, we also do independent testing ourselves to make sure that that narrow range has been met and the product is as consistent as possible, batch to batch.
Thank you. Let's have a look at another question. Would a doctor be able to prescribe for insomnia caused by long COVID, or would the prescription have to be for long COVID specifically? Well, from the UK, a doctor can prescribe for any condition in which he or she thinks is in the best interest of the patient. So you don't have to worry about sort of saying that they've got insomnia or they've got anxiety. You can do what you like, basically. Not many doctors are doing that, I have to say. But nevertheless, you don't have to have insomnia or anxiety or whatever to get a prescription for long COVID. You can, if the doctor thinks that's a reasonable treatment choice, you can have it. That's the UK. That's the UK regulations anyway.
That's
yeah,
right.
Anjali, yeah.
And it's not licensed here either. So once it's licensed, then we feel like we're always covered in terms of if there were side effects, and people question prescriptions when either they don't work, they're too expensive, or you get side effects. So I usually write that in my consent form. So very similar to Australia, it's not licensed here. So I do write a consent form to say we have discussed our medicinal cannabis use. If there's THC, there's driving involved. But I also write a very small sentence in that consent form. I'm very happy to share that I've written myself with the help of my medical legal insurance. That it says that this is a trial that I cannot promise may help you, but at this point we have agreed that you will try this to see if it will help. And usually my trials last 3 to 4 weeks. Takes a little while to equilibrate. So if that helps you prescribe for unlicensed reasons, the idea is you need to be aware that the safety profile is quite good for medicinal cannabis. And there is also some cardioprotective research coming out for the elderly in low doses of CBD dominant. So I'll let you read that with the research.
Thank you. David Tang says, what are the barriers to recruiting more patients of these types of trials? They're very low powered. They are indeed. I don't think there are barriers per se. It's a matter of setting up the trial and recruiting people to it. Despina or Adele, do you want to comment on the recruitment to the trial?
Yeah, that's true, Mike. But also, interestingly, that with the study that we are about to embark very soon, there was the barriers or the limitation or challenge actually that we had was MHRA, that not being very familiar with the use of the medicinal cannabis as for the study. So lots of questions being asked, even though there are prescription, but they just not feeling comfortable to use that in the clinical trial. With the long COVID, that's fine. You know, they are supporting studies, but the use of the medicinal cannabis for that, it was a lot of challenge. We overcame all of those challenges, which is great. But that I don't know that if every single company be able to go through all these hurdles and all those documentation that they require. So that makes it a bit difficult. But generally speaking, I don't see that recruitment be an issue because of the number of the people available and having these issues, as well as the interest that they have, that they tried many other medications, didn't work. So they would like to use something different as a medicinal cannabis, for example.
And related to that, while we're on that, Despina, a question from Julian Birch. If we're both interested in taking part in the UK trials, how can we refer them? Do you want to answer that one?
Yeah, sure. I think the easiest thing to do is just send an email through to info@bodpharmaceuticals.com, and I'll put that in the chat as well, and we'll be able to direct you from there.
Great, thank you. This is a long, I'll read it out quickly. This is from Anonymous. A person with long COVID didn't use the word fatigue is misleading. You know, I sort of agree with that, because fatigue sort of has an implication in the English language of, well, I'm a little bit tired tonight. And I know that the fatigue of COVID and the fatigue of brain injury and such like an MS is much, much worse and overwhelmingly worse than that. It's not really the right word. Anyway, sorry, I digress. It's more in line with spoon theory. I don't know what that is. In that, for many of us, our resources are depleted, so our capacity for activity is reduced. Please comment as well. I'm curious why the neurological symptoms such as disequilibrium are not widely cited. It seems a primary symptom for many people in the long COVID support group. Does CBD help with disequilibrium? Anyone to answer whether CBD helps with disequilibrium? Quick
May
answers.
I just say,
yeah.
The answer, yes, yeah. In practice, it's very hard in evidence-based practice to get good qualitative research without confounding factors. So the reason it's not in mainstream is because it's very hard to isolate these symptoms and differentiate them, and then use a medicine and with evidence show that there's absolutely zero confounding factors in the trial. And I show, as I presented my case, you saw that I did tell you all the other medications that we were trying. I feel like it would be a malevolence to not offer all the other medications, because if I really wanted to truly check whether CBD worked, I would just avoid the other medications. But as practicing clinicians, we can't do that. So it's very hard, but I'm very aware that this is slightly different to chronic fatigue, even though I've seen quite severe chronic fatigue here as well. Here we've a very, very good system. And I feel sorry for the GPs in the UK that are not able to spend 45 minutes with their patients to work out where they go next, because sometimes these symptoms are put under the radar. But CBD is a very good trial. And maybe if you wanted to know, you would try it. I feel like you could only check with practicing and working out in your clinical practice if you felt it helped. And there is always places in your treatment plan that you could inject it as a trial when other things are not working.
Okay, we've got a couple of questions on microclots. Would a CTPA being negative rule out microclots in small peripheral vessels? Are we missing these? It's a good question. I don't know. Anyone to answer that?
So that first case, I feel like they were trying to work that out with the, is it called the carbon monoxide PE? Sorry, I think there is a slide there, isn't there, when they do the gas exchange transfer to check whether there is the correct amount of carbon monoxide being expelled. I'm so sorry, this is the respiratory people. So they did respiratory function tests every couple of months. They've done 2 CTPAs on admission to the ED. They've done the gas transfer tests and they were all negative. So I feel like with this first case study I talked about, he was fully investigated and I felt it was a very good case, because I could tell you that for the post acute COVID-19 sequelae, the things he was telling us, and what I didn't tell you is he had full EMG studies, he had an MRI brain, he had an MRI spine. The fact he was a financier in central London, was private health insured up to the hill. He was seeing a doctor twice a week, and lots of professors in London that I had heard of when I was teaching, and some people that taught me. So I feel like he was fully investigated. For this case, possibly we didn't miss anything. For other cases, possibly we might be missing microclots, but maybe we would see that in our respiratory function tests and gas exchange tests in the future. How to treat that, I don't know yet.
And Carl makes a very good point. There's a lot of people suffer from post-viral fatigue syndrome. I think personally, as purely, I have no evidence for saying this. I think long COVID is another example of post-viral fatigue syndrome that we know follows, as Carl has said there, SARS-1, Coxsackie enterovirus, etc. And we do need more research on it. What is it that makes some people, like the case we heard, have a long post-viral problem? We just don't know. I think you're quite right, Carl. We need much more research on that, because it's, as you said at the bottom there, many have remained with symptoms for years, a group known as the millions missing, and he used to be one of them. So yeah, all I can do is agree with you and say that I think it's another example of a post-viral, let's call it, it's more than fatigue, but a post-viral syndrome. And we need more research on it. Quickly now, because I promised to finish it. It's 8:11 now, so I haven't kept to my word. But patient palpitations, would you go on to order Holter studies? Yes, yeah. Yes, I think you would, to make sure it's not something cardiologically you can treat. And finally, in Israel, unable to keep consistent cannabis for medical use. Sure, where I think, as I said before, it's not totally consistent, but many cases where it can be reasonably consistent, enough certainly to treat, as we've talked about today. And finally, Ilya has said we'll have multiple cases of patients who use cannabis for medical purposes who contracted COVID. Sure, I don't think cannabis prevents COVID. I think it might reduce the risk of long COVID. It doesn't protect you from getting it in the first place. I'm not aware of any evidence it does that. We describe our experience to work with them, so thank you. Let's hope for that will be published. We'll learn more about this rather mysterious so far and very debilitating long COVID symptom complex. So thank you.